Hi, everyone. This is Lisa Wessel with Encompass Women's Health. We're glad you're here today. Subscribe, like us. I'm here with Diane, and today we're going to talk about the thyroid. The reason I wanted to talk about the thyroid specifically was that a lot of things that happen with the thyroid can overlap symptomology of perimenopause and menopause. It's an extremely important endocrine system that we typically have checked, but not the full picture. Signs and symptoms of the thyroid not working can be fatigue and brain fog and concentration problems. I always tell people sometimes it feels like you're moving underwater, just like slow motion, and or to me it's like Charlie Brown teacher when people talk to you, wah wah wah, when you're like, what? Like that's what it always reminds me of, or that's what I think of. Very overlapping of perimenopause, menopause symptoms. Like I don't feel like myself, I'm gaining weight, I think it is an important topic to talk about. And this is why, as far as lab work, if you're getting worked up or you're thinking it's hormonal, is always, always, always thyroid should be included in that panel. It is a problem. But conventionally, as providers, we are taught to check a thyroid stimulating hormone. And if that is normal, the thyroid is normal. And the thyroid stimulating hormone is in the hypothalamus, and it is the manager. It talks to the thyroid, and your thyroid sits right here. And you can, if you put your hand on your neck and swallow, you'll feel it. It'll go up and down. And it's like this rubbery. That's what we do is we feel it during an exam. I have a little nodule somewhere. That's what we're feeling. And then that's what we should be checking. But if we only check the signal from the brain, talking to the thyroid, we're missing the rest of the thyroid. So we should check a TSH. We should check a T3. We should check a T4, and we should always check for any antibodies. There's a lot more that you can check with the thyroid, but those would be the basics. So you are looking for the signal to the thyroid. Am I yelling at you? The way it's supposed to be is we have a reference range of a TSH of 0.45 to 4.5. So really, really broad. It is, and it's always opposite of what people think. So they think, you're hypo, so the number would be low. Hyper, with the number would be high, but it's actually the opposite. If your number of a TSH is closer to that 4.5, really anything above 2, that means I'm having to yell. So normally, we all go to work. If I'm the boss, if I'm the TSH, then everyone knows what to do. I've already told you what to do. We've done it. We've showed you. You've been oriented. You've gotten checked off, and you know what your job is. So I don't have to be there. You should come to work and you start. If you think of like of a factory line or something like that, no
Mhm.
one, everyone just goes and does their job. But what starts to happen is if I'm the boss and I come in and I'm like, what the hell? Why isn't anyone working? And I have to like open the door and be like, hey, Diane, come on, let's go, let's go, let's go. And then you're like, oh, okay. You would start, that would be the TSH rising. So if I have to talk to you at all, if I have to raise my voice to you, that is a sign that the thyroid isn't working optimally.
The thyroid is independent. You go do your thing, you've got the job. I don't wanna have to micromanage you, and if I'm gonna have to micromanage you, I'm gonna be irritated,
Yeah.
and we're gonna have further discussions.
We have to have further discussions, and I don't want to talk to you. I already did that. I've already told you. So that's the TSH, and then you should be looking at the thyroid itself. So that's where you're looking at a T3, and you're looking at a T4. I like to describe that is T3 is the worker bee. It is the one doing all the work. If you'd like to, like a different analogy, like it is the person running the marathon. It is the one doing the work, and that's what it's supposed to be doing. That reference range is 2 to 4.4. Again, really broad. So you really want to see a T3 like 3 or above. Like there's like I always kind of like if you could draw a circle around that. Like this is okay. When T3 starts to get under 3, it's starting to struggle. Like it's doing the job, but it's getting harder and harder to do the job. If you're watching it and seeing like, okay, I was at 3.3 and now I'm at 3 and then I was at 2.8. Like what is going on? Like I'm getting the job done. If you compare it to like a marathon runner, when I start to see around 2.5 and less, you're still in the race, but you're walking and you're
Right,
having to take some
right.
breaks. And then if you're getting down to 2, you're literally like, I'm out. Like what starts to happen is T3 gets lower and lower and lower and lower. Then you'll start to see the TSH start to go up because like, hey, T3, where are you? What's going on? So if we're only looking at a T3, it can maintain a number for a long time. And then you're trying to catch it before that happens, before people feel off.
Which is why it's important to consistently get the blood work so you can
Yeah.
see the pattern over time, not necessarily what the range tells you from the lab.
And yeah, and then T4 is the savings account. T4's job is just to support T3. Do you need water? What can I do to help you? Like, you gotta let me, you want to rub that cramp out? Like, that's its job. So T3 will grab T4, convert it to T3, and like keep going. So you're looking at all of those numbers. I think one of the most important things to look at too is antibodies. Well, that's hardly ever checked. And there's a lot of people, like 30 to 40% of people are walking around with antibodies, which we call, that means it's like there's a diagnosis. You have Hashimoto's thyroiditis. There's an autoimmune issue going on in your system that your thyroid is under attack. And so your thyroid can be under attack, but it's like, we're good. I know you're here and you're attacking us, but like, we've got a really strong unit and you're not going to push me off. But over time, like, our body can't sustain over and over and over again. So
Right.
it's like, when you see that, it doesn't necessarily mean, oh, you need to be on medication. It's like, okay, what are things that we can do to support the thyroid? What are some supplement, what are some minerals that can be supportive? What are things we can do dietary to support the thyroid? For myself, I've always had a really good TSH, but when you looked at the numbers, my T3 just kept getting lower and lower and lower and lower until it was like not existent. And I was like hesitant, I didn't really want to be on anything. And it was funny because I went on medicine and I was taking thyroid medicine and was like, okay, that's great. I felt good. I'm a patient like everyone else. I don't know that I need to be on this. I'm going to stop. And about 2 weeks after being off my medication, I was like, what the hell is wrong with me? And that's where I got that. That's like how I describe it. I was like, I remember walking out the front door and I was like, what? And I'm like, oh, you stopped taking your thyroid medicine. That's what it is.
Okay.
And then I felt better when I was like, oh, the systems are in place for a reason. And it is a very well oiled machine and things that, how it needs to work. And if it's doesn't, again, you have to have that T3 and you have to have the T4. And if we're only looking at one marker, then we can be missing a lot of things. Keep in mind, like the reference ranges I was giving, like they're very broad. The only one that's not is your T4. Your T4 reference range is pretty narrow. Typically they'll say zero point 0.8 to 1.8. You like to see that above one. And the other thing I like to tell people is, people who have had a thyroid problem and who've been on medications, they usually know their numbers and they usually know where they feel best. Some people, they do better when T3's up, here, this and they can tell. I think that's the piece too, is really just part of it is just having the full lab checked, like looking at the whole picture, getting a really good idea of what is going on. The endocrine system, it's the same as our hormonal systems. If you put it together, we have a thyroid stimulating hormone. That's for the thyroid. So we're talking TSH, T3, T4, antibodies. We have the follicle stimulating hormones, still a signal from the brain to the ovaries. When you have a system like that, you have a manager and you have worker bees. So if all I'm doing is checking a follicle stimulating hormone on you, Diane, and going, yeah, look, you're not in menopause. Like, that's all that's telling me, but it doesn't tell me
Right.
anything else. It doesn't give me any idea of what your hormones are like. What does everything else look like? So it's important to look at the full pictures. That's the point of today's topic. Is when you get those checked, like ask for that, the full thing.
Now, let's talk a little bit about nodules because I have one, you have one. From what I understand, they're not uncommon. Uh, Talk a little bit about what nodules are.
Well, there's different, people will get nodules on their thyroid, which can be just benign cysts, essentially. There is a algorithm of like the size. Yep, we see that it's only this big. At that size, we're gonna have you come back in a year. We're gonna monitor it. If it's this big, then we want a biopsy. Biopsies of any kind aren't always 100%. You have to get like the perfect spot. People have a lot of issues, concerns. They're concerned about cancer. They remove the thyroid because of it. Now you don't have a thyroid and now you're on medication forever. Medicine is sometimes like hindsight is 2020. Like, we don't know. We don't have a way. We can tell you this is what it looks like. This is what it's consistent with, but we're not sure until you do something. And sometimes it depends how big it is. Can you remove the cyst, the nodule, or is it the full thyroid? And sometimes you don't know that until you get in there. I'm not a surgeon, but that's what ends up happening. So you'll have cysts, you'll also have goiters, and people still develop goiters. And if you know what you're looking for, like if you're looking in this area, let's make it so my neck looks nice and young. You'll see like this will stick out almost like there was like a lemon, and you can start to see it. So what providers are doing when you're talking to someone like, I'm looking at you. How are you talking? What does their neck look like? People develop goiters all the time. They do just happen. You can have deficiencies, but they just get big and they remove them. And sometimes people will lose their thyroid. I think people like the importance of the thyroid is ginormous. It's a master gland. It's constantly working. It's constantly under attack due to our environment, the things that it's trying to process that it doesn't even know what it is because those things didn't exist 10, 20, 30 years ago, 5 years ago, 2 years ago. It's really this filtration system that our bodies, so when they talk about endocrine disruptors, that's what they're talking about. Like, comes into our system and I don't know what to do with this. So there's a lot of things that attack the thyroid.
That's fascinating, and we just don't talk a lot about it aside from that one little marker.
And when you can't assume that when you say, "I want a full thyroid check," that that's what's gonna happen. You're gonna get a TSH. So you have to say, "I'd like my TSH, my free T3, my free T4, and I'd like a TPO checked." Be specific. Yeah.
And we'll put those specific markers in the,
Yeah.
notes. What is the medication typically for thyroid?
Most people are on Synthroid or levothyroxine. Levothyroxine is the one. Synthroid, I think, is the generic name of it, or it could be the other way around. And those are specifically a T4. So where you're supporting the T4, that helps with the conversion. Those are the standard ones. I would tell you
Mhm.
that a lot of people do better when we work more on the T3, where that is going to be more what's called a desiccated thyroid, like NP thyroid, Armour thyroid. There's a lot of information out there because T3 came to the market probably later in the game, and it is made from pig thyroid. And so, where your Synthroid and levothyroxine are a synthetic version, this comes from an animal, so that is important for some people who will not, can't have any animal product. The thought we were all taught in school was that it's not regulated and you're getting different dosing all the time, and that is not true. That may have been true back in 1945, but it's come a very long way. But like that, it's funny because like when something gets established like that, that's kind of what you know. And so like I was taught that like, nope, it's not regulated. And it's hard. You're getting different dosing all the time, even though you're on 60 milligrams. And that is not true, where it's a very great option for people and people do really well with it. There can be a lot of non-responders and it either works or it doesn't. It is something you monitor. Anytime you're doing any thyroid medication, you're checking levels usually between 4 and 6 weeks. 4 weeks with pregnancy, we're checking more often. If we're not, it's like usually around the 6 to 8 week mark. And every provider is a little different, but that's what you're looking for. If you're giving a thyroid medication and it's too much for your body without even checking it, people will start having the side effects are opposite. If you are hypo, I can make you hyper. You're not having anxiety, you're having heart palpitations. It's too much. I think
Okay.
one of the side effects that people don't necessarily correlate is like leg cramps at night. You just have like a lot of Charlie horses can be a sign that your thyroid medicines could be too high. It speeds everything up. And so that if you're starting to, what's going on there? Maybe we need to check your thyroid. You could start with supplements. You could do some supportive therapy. You could look at diet, reduction of gluten, reduction of sugar, reduction of alcohol. Dairy can be very inflammatory. Actually, dairy is probably the worst insult to everyone thinks gluten, but it's dairy, can be very inflammatory to the thyroid.
Awesome. I have one other question.
Yeah.
Is there anything people can do to protect their thyroid? Environmental factors? I mean, that's hard
Yeah.
because it's life and it's
It is
living
hard.
life.
We can there's EUG, like you can get on and see like endocrine disruptors. What are like the major causes? Dietary, again, it's gluten, it's sugar, it's all the things though. It's dairy, it's alcohol. Where can I make reductions? What could be helpful? Dairy is probably the biggest offender to the thyroid. Gluten is pretty strong up there too. Sugar, your processed foods. We know like it's just, candles, those hangy things that people put in their car to make it smell good are awful. What are we using in our hair and our face? Perfume, those sorts of things. Like we're better off using essential oils than you are just because what's put in everything. So things like that you can
Mhm.
start looking at. Detoxifying yourself, drinking your water, lemon water, sweating, exercise, eating well.
Oh,
You're not gonna fix the
thanks.
thyroid that way. That's kinda bullshit for me to say that. You're not gonna fix it. It can just be helpful. Like you can't there's certain things you can do to be that are helpful. Things can get better, but you're not necessarily it's like not like I don't wanna say like we're doing something wrong or you're you can pray it away sort of thing because you can't always do that. So,
All right. Well, thank you very much.
yeah.
And thank you all for listening and tuning in. And we will be back next week.
All right, guys, take care.